Hello, everyone. Welcome to another ICD-10 CM guidelines session. Today, we're going to focus on section 1B, which are the general coding guidelines. As a reminder, as we discussed in section 1A, the guidelines are the basic concepts that coders must understand in order to assign our ICD-10 CM codes accurately and completely. In this portion of the guidelines, the general coding guidelines actually describe how to locate a code and how to apply all of the necessary rules to fully describe the patient's condition and/or reason for the health services encounter. These guidelines have a total of 19 components. Let's begin. First is guideline number 1, which speaks to the process for locating a code in ICD-10 CM. As we discussed in our first segment, coders are required to utilize both the alphabetical and tabular lists to locate their particular code. The reason that we must utilize the alphabetical index and the tabular list is because the alphabetical index doesn't provide you with everything you need to have the most specific code. For example, in the alphabetical index, you're not going to see all of those instructional notes that we spoke of in our first session. Remember, includes, excludes, code first, use additional code. All of those notations are not in the alphabetical index. Also, the alphabetical index does not always give you the complete code because, as you may recall, some of our codes have to be carried out to the 7th character position. The tabular list is critical in ensuring that you're capturing the most accurate and most specific and the most complete ICD-10 CM code. Guideline number 2, the level of detail in coding. As you know, we always want to code our conditions to the highest level of specificity. So very simply put, what that means is if there is an option to report a 4th, a 5th, 6th, or 7th character for a code, reporting the 3-digit code would make that particular code assignment invalid. So we always want to code to the highest level of specificity. Next, guideline number 3, which focuses on codes from A00.0 through Z99.8. Now, these particular codes here, and you see the code ranges there, those codes have to be used to classify our patient's diagnoses or the symptoms that they may present with, conditions, problems, or any other reason that our patient presents for a healthcare encounter. Next, speaking of signs and symptoms, guideline number 4 tells us that signs and symptoms, as opposed to diagnoses, can be reported when a definitive or a confirmed diagnosis has not been established. In your tabular listing, chapter 18, you are able to locate many, but not all, of the sign and symptom codes. Now, notice I said many and not all because some of the signs and symptom codes are captured in the disease categories that relate to that condition. Guideline number 5, conditions that are an integral part of the disease process. As a coding specialist, it is important that you have a full understanding of the disease process because signs and symptoms that are routinely connected to a disease process should not be coded as an additional code unless the ICD-10 system says otherwise. Next up, Guideline 6, conditions that are not an integral part of a disease process. So Guideline 5 speaks to conditions that are an integral part of a disease process. Guideline 6 focuses on conditions that are not an integral part of the disease process. In these situations, we can assign an additional code. Now, this goes back to something I just mentioned a few seconds ago, and that is, as a coding specialist, you must understand the disease process, as this is a critical component of being able to recognize if a sign or symptom is routinely associated with the disease. Next up, guideline number 7, multiple coding for a single condition. Now, remember in our section 1A video, we looked at guideline 1A13. That guideline focused on etiology and manifestation conventions. That is, those instructional notes that are code first, use additional code, and then end diseases classified elsewhere. So multiple coding is a situation where the patient's problem requires 2 codes to fully describe a condition that affects multiple body systems. In your code manual, when this situation applies, you're going to see notes such as code first. We actually saw this in our very first video, section 1AB, and if you need a review, go back and take a look at that portion. Code, if applicable, any causal condition first. This is letting you know, if applicable, something else should be coded first. Other situations regarding multiple coding may be needed when the patient has a sequela, that's the sequel to the original condition, or complication codes or obstetric codes that are needed to fully describe a condition. Next up, acute and chronic conditions. Now, as you know, an acute condition is something that's happening right now, whereas a chronic condition is something that is present over a period of time. It's a long-term condition. So according to the ICD-10 CM guidelines, if the patient has both an acute condition and a chronic form of that condition, if the alphabetical index at the same indentation level, we spoke about the indentation level in our first video. So if the alphabetical index has separate entries at the same indentation level for both the acute and the chronic form of that disease, both codes are assigned. There is, however, a sequencing rule, and that is the acute condition, what is happening right now, should be sequenced first. Next up, our guideline number 9 for combination codes. A combination code is actually a single code that can classify either 2 diagnoses, a diagnosis with an associated manifestation, or a diagnosis with an associated complication. Now, one thing I want you to note to differentiate this guideline, guideline 9, from guideline number 7, is the fact that these are combination codes that's giving us the condition and the manifestation, or the condition and the complication, all in one code. Whereas in guideline 7, we looked at multiple codes. Of note, your combination codes are actually identified by referring to your subterms in the alphabetical index and reading your instructional notes. Now, the funny thing is, in our first video, we spoke about those instructional notes. Of note, when a combination code lacks the necessary specificity in describing the manifestation or complication, an additional code can be used as a secondary code. Next up, guideline number 10, which is for the sequela, also known as late effects. A sequela is really the residual effect or the condition that was produced after the acute phase of an illness or injury is over. There is no time limit when a sequela can be used. Your provider will document that in the medical record. The sequela could be early, or it could be years later. An example of when it's early could be if a patient has a cerebral infarction and they have dysphagia. An example of when it could be a longer period of time can be when the patient has a scar formation after a burn heals. Now, coding of the sequela is generally going to require 2 codes. The first code is going to identify the condition or the nature of the sequela. And then the sequela code is going to be sequenced second. There are some exceptions to the guidelines that I just presented. And it's for those instances where the code for the sequela is followed by a manifestation code as identified in your tabular list or in the title, or the sequela code itself where it has been expanded out to the 4th, 5th, 6th levels to include the manifestation. So one thing that you probably want to remember, you must always verify your code in the tabular list. One more note regarding sequela. The code for the acute phase of an illness or injury that actually led to the sequela should never be used with the code for the late effect. All right, on to guideline number 11, which focuses on impending or threatened conditions. According to guidelines, and we're still in section 1, letter B, this is number 11, code any condition described at the time of discharge as impending or threatened as follows. Number 1, if the condition did occur, life is good. We code it as a confirmed because it's no longer impending or threatened. If the condition did not occur, that's when things are going to change for us. First, we're going to follow the guidance in our alphabetical index to determine if that condition has a sub-entry or a subterm for the word impending and or threatened. And also, you're going to reference main term entries for the words impending or threatened. So you're going to check in both places. If the subterms are not listed, code the existing underlying condition and not the condition described as impending or threatened. So if the subterms are listed, you can assign the code. But if they're not listed, you have to code the underlying condition. Next up, guideline number B12, reporting the same diagnosis code more than once. So for a given encounter, each unique individual ICD-10 CM code can only be reported once. Now, you may be thinking, well, what about situations when a patient has a bilateral condition and there is no code that shows left, right, or bilateral? Can I just report that same code twice? And the answer is no. Why? Each unique code can only be assigned once per encounter. Speaking of laterality, some of our ICD-10 CM codes indicate laterality. That is the condition on the left side, the right side, or is it bilateral? So here are the rules. If no bilateral code is provided in your index, your tabular list, and the condition is bilateral, you're going to assign the code that says left side and right side. Now, remember, if there is only one option, you have to assign that one code. If the side, the left or right body part, is not specified in the medical record, most code families have a code for unspecified side. That means the doctor doesn't know, or it was not documented. Now, when the patient has a bilateral condition and each side is treated during separate encounters, you can assign a bilateral code as long as the condition is present on both sides. Because maybe this visit, they focus on the left side, and that visit, they focus on the right side, but both sides are still impacted. You can actually assign the bilateral code. Now, for your second encounter for treatment, after one side is now treated and healed and that condition no longer exists, then you're going to go and focus on the unilateral code for the side where the condition still exists, where the patient is still having the problem. In the guidelines, we receive an example of a patient that had cataract surgery performed one encounter on one eye and then the next encounter on on the other eye, because maybe they're not going to do both cataracts during that encounter, but that still does not negate the fact that the patient still has the bilateral cataracts. Now, in this situation, the bilateral code would not be assigned on the separate encounter if the patient no longer has the treatment. Now, if the treatment on the first side did not completely get rid of the issue, then you can still assign the bilateral code. So really what all of this means is, does the patient still have the condition? That's the first question we have to ask ourselves. And then, what's being treated, and apply the applicable guidelines. All right, next up, guideline 14, documentation by clinicians other than the patient's provider. Now, let's think about that for a second, and who are we actually talking about? Well, you can have a stroke scale, an ulcer stage, coma scale, the BMI documented by other professionals that are working with the patient, such as a nurse or a dietitian or emergency medical technician. And so that's when these guidelines apply. So first, code assignment is based on the documentation by the patient's provider. That is either the physician or the qualified healthcare professional that is legally responsible. This is the person that has the license, that's accountable for establishing the patient's diagnosis. Now, the exceptions to this rule are BMI, the death of a chronic ulcer, the pressure ulcer stage, the coma scale, and the stroke scale codes. In these situations, and these are exceptions, code assignment may be based on the medical record from these other clinicians. So the dietitian sees the patient and they document the BMI, but the patient already is diagnosed with obesity. So that's something that is key. The associated diagnoses must be documented by the patient's provider. And in those situations where the medical record documentation is conflicting from either the same clinician or different clinicians, the attending provider, I like to call them the captain of the ship, they should be queried for clarification. Now, other types of documentation by clinicians other than the patient's provider are our codes Z55 through Z65 for social determinants of health. So these are the patients that have potential health hazards related to their socioeconomic and socio or psychosocial circumstances. In this particular situation, code assignment may be based on the documentation from clinicians that are actually involved in the patient's care who are not the patient's provider, given that this information represents social information and not a medical diagnosis. So a patient who's having housing issues is an example. Guideline number 15 focuses on syndromes. Coders should follow the alphabetical index when coding syndromes. So what this means, if a patient has a syndrome, you want to go to the alphabetical index and locate the main term of syndrome. Now, in those situations where the alphabetical index lacks guidance regarding syndromes, you're going to assign codes for the documented manifestations of that particular syndrome. Also, additional codes for the manifestation that are not an integral part of the disease process may also be assigned when the condition itself does not have a unique code. All right, next up, documentations for complication of care. Now here, code assignment is based on the provider's documentation of the cause and effect relationship between the condition and the care or the procedure, unless the classification, the ICD-10 CM, provides different guidance. The guideline actually extends to any complication of care, and that's irregardless of what chapter we're in. It's also important to note that not all conditions occur during or following medical care or surgery and are classified as complications. Again, must be a cause and effect relationship between the care provided and the condition, and an indication in the medical record documentation that the condition is a complication. When we're not sure, of course, we should query our provider. Guideline 17 focuses on borderline diagnoses. Now, borderline diagnoses is something that you may see documented in the patient encounter at the completion of the encounter. The diagnosis is coded as confirmed unless the index, ICD-10 CM index, has a specific entry, such as borderline diagnoses, borderline personality disorder. You'll see this in the alphabetical index. So if a borderline condition has a specific entry in ICD-10 CM, it should be coded as such. Since borderline conditions are not uncertain diagnoses, there is no distinction made between the setting, so that's inpatient versus outpatient. And As it relates to uncertain diagnoses, we will cover that in subsequent video segments. Of course, whenever the documentation is unclear, we should query our provider. Next up, Guidelines 18 for the use of sign or symptom codes. So sign and symptom codes, they have an acceptable and even a necessary use because there may be situations when that's all that we know. So while specific diagnoses should be reported when they're supported by the medical record documentation and the clinical knowledge of the patient's health condition or status, there are instances when signs and symptoms or the unspecified code is your best choice for accurately reflecting what has happened during the health encounter. Each and every encounter should be evaluated and coded to the highest level of specificity based upon what is documented for that encounter. If the provider has not established a definitive diagnosis at the end of the encounter, it is acceptable to report the code for the sign or symptom. Now, when sufficient clinical information isn't known or available about a particular health condition to assign a more specific code, then it is acceptable to report an unspecified code. Now, unspecified codes should be reported when they are the only option that you have. And a lot of payers actually don't like specified codes. And that's why clinical documentation improvement is so very important. It would actually be inappropriate to select a code that is not supported by the medical record documentation, or situations where medically unnecessary diagnostic tests is performed in order to determine a more specific code. All right, our last guideline for section 1B focuses on coding for encounters in hurricane aftermath. So this particular guideline is actually brand new for fiscal year 2019, and it consists of 4 parts. So we're going to start with Part A, 19A. So Section 1, letter B, 19A. So this particular guideline focuses on the use of external cause morbidity codes. So the external cause morbidity codes should be assigned to identify the cause of injury or injuries incurred as a result of a hurricane. The use of these codes, it should be noted, are supplemental to the application of the ICD-10 CM codes. As you may or may not know, the external cause codes, the external causes of morbidity, are never to be recorded as a first listed or principal diagnosis. That said, the appropriate injury should actually be sequenced first before the external cause code. Now, in another video segment, we'll look at our external cause of morbidity codes, but just for purposes of this guideline, you should know that the external cause or morbidity codes capture how the injury or illness happened, that's the cause, the intent, whether it was intentional or unintentional, such as an accident or suicide or assault, the place of occurrence, the activity of the patient, and the patient's status, whether they're civilian or military. Now, these codes should not be assigned for encounters to treat hurricane victims' medical conditions when there is no injury, adverse effect, or poisoning that is involved. External cause of morbidity codes should be assigned for each encounter for care and treatment of delivery. Now, something else that's important to note, these codes can be assigned in all healthcare settings, inpatient, outpatient, you name it. For purpose of capturing complete and accurate ICD-10 data in the aftermath of a hurricane, a healthcare setting should be considered as any location where medical care is actually provided by a licensed healthcare professional. All right, that was guideline A. Guideline B, sequencing of the external cause morbidity codes. Again, we're not talking about the morbidity code guidelines per se, but something else you should be aware of, and this relates to sequencing. Our codes for our cataclysmic events, such as hurricanes, actually take priority over all of the other external cause codes. However, there are some exceptions, such as child and adult abuse and terrorism, and those should be sequenced before any other external cause codes. As stated in our external causes of morbidity guidelines, we can actually assign as many external cause codes as necessary to explain each cause of a condition. Now, for injuries that occurred as a direct result of the hurricane, you're going to assign the appropriate code for the injuries, followed by code X37.0 with the appropriate seventh character. Remember, we talked about the seventh character in the first video. So one of the things you'll want to remember is that placeholder character that we talked about. In addition to the code from category X37, which is hurricane, you're also going to assign any other applicable external cause of injury codes. Now, code X37.0 should be assigned when an illness or injury incurred as a result of things like flooding caused by the levee breaking related to a hurricane. We've seen that before. There are also codes X38 for flood, X36 category for a collapse of a dam. So be sure to check those codes and related guidelines out if you are going to be utilizing this particular section. All right, next to last, this is guideline C, which is other external causes of morbidity code issues. So when you have situations where there's an injury that's not a direct result of a hurricane, such as an evacuee has occurred an injury as a result of a motor vehicle accident, you're going to assign the appropriate external cause of morbidity codes to describe the cause of injury, but you're not going to assign X37, that hurricane code. Now, if it is not clear whether the injury was a direct result of the hurricane, assume, and this is what the guidelines say, folks, assume the injury is due to the hurricane and assign X37. Now, in addition to the X37 codes, there are some other possible external cause codes like bitten by a dog, exposure to excessive heat, exposure to excessive cold, as well as a flood code. Lastly, use of Z codes. Z codes, which are the other reasons for healthcare encounter codes, may be assigned as appropriate to further explain the reasons for presenting for healthcare services, and this is including transfers to other facilities. The ICD-10 CM guidelines identify which codes may be assigned as principal or first listed, and which of those Z codes can only be listed second. Be sure to check that out. This is found in your guidelines where the Z codes are listed. Some options for hurricane aftermath could be some of our social determinant codes, such as homelessness, inadequate housing, extreme poverty, situations where patients are waiting for admission to an adequate facility elsewhere. And then we also have codes for unavailability and inaccessibility of healthcare facilities. All right, guys, this has been your introduction to ICD-10 CM Guidelines, Section 1B, which again are your general coding guidelines. In our next segments, we will begin to unpack Section 1C, which are your chapter-specific guidelines. And as you may recall from Section 1A, ICD-10 CM has 21 sections. However, not all sections have guidelines. This has been Dr. Campbell with Dr. Campbell's Coding Corner, and thank you for listening.